Good evening and good morning to our colleagues in Asia. Thank you for joining us, if only virtually, here at the Shorenstein Asia Pacific Research Center at Stanford University. Before introducing our distinguished speaker, and in line with our focus on health, resilience, and inclusiveness, we would like to start with a land acknowledgement voiced by our students.
Stanford sits on the ancestral lands of the Muwekma Ohlone tribe.
This land was and continues to be of great importance to the Ohlone people.
Consistent with our values of community and inclusion,
We have a responsibility to acknowledge, honor, and make visible
the university's relationship to Native peoples.
Thank you. I'm Karen Eggleston, Director of the Stanford Asia Health Policy Program, and I'm delighted to welcome you to this inaugural webinar of our series on aligning incentives for better health and more resilient health systems in Asia. We have events coming up on hospital payment reforms in China in 2 weeks, and then in November on Indonesia beyond COVID and the impact of climate change on mortality across Asia. We invite you to join for those events or view the recordings afterwards. For today's webinar, we're delighted to partner with Stanford's Center for South Asia and the South Asia Initiative here at APARC. Our keynote speaker is Professor Mushfiq Mobarak, a professor of economics at Yale University with concurrent appointments in the School of Management and in the Department of Economics. He is the founder and faculty director of the Yale Research Initiative on Innovation and Scale, and holds other appointments at Innovations for Poverty Action, the Jameel Poverty Action Lab at MIT, and the International Growth Center at LSE. Professor Mobarak has several ongoing research projects in Bangladesh and elsewhere, such as Nepal and Indonesia, conducting field experiments, exploring ways to induce people to adopt technologies or behaviors that are likely to be welfare improving, and examining the complexities of scaling up such development interventions. He has collaborated with the government of Bangladesh, NGOs, think tanks, and many others, including colleagues here at Stanford, to devise evidence-based COVID response strategies for Bangladesh and for other developing countries, which he will share with us today. His research has been covered by the New York Times, The Economist, Science, Foreign Policy, BBC, and many others, and has been published in journals across several disciplines, including Econometrica, Science, the American Political Science Review, Proceedings of the National Academy of Sciences, and Demography. After Professor Mobarak's presentation, we have a few minutes to discuss your questions, which we invite you to submit through the Q&A function. So Professor Mobarak, thank you for being with us today. Over to you.
Thanks very much for having me, and I will share my screen in order to get started. Okay. So there are maybe 3 things I'll talk about today, and I'm going to try to do it quickly so that we have ample opportunity for Q&A. So the first thing is I'd like to tell you a little bit about what the pandemic has looked like in developing countries and low and middle income countries, and what policy responses look like because I think low and middle income countries demanded a distinct policy response, and also the effects of the pandemic were a lot more severe. And second, we'll talk about the fact that one of the things that's become very clear is that in developing countries, we're not going to have access to vaccination coverage. And so masking remains very important. So I'll tell you results from the MASK trial. And third, I'll talk about whether or not we can apply those same ideas and what we are planning to experiment with in terms of getting last mile vaccination coverage or more efficient last mile vaccination delivery once those vaccines do arrive in poorer countries. Okay, so on the first piece, even very, very early in the pandemic, right, we were, as the virus had hit rich countries like US, UK, and it hadn't yet hit countries like Bangladesh, Nepal, Sierra Leone. We were extremely worried, and it was a very data poor environment. So one of the first things we did was started doing high frequency data collection on both the public health aspects of the crisis, but in developing countries, it's also equally important to look at the economic aspects of the crisis, because this was as much an economic shock as it was a public health shock. And so we collected data on the prevalence of symptoms around these countries, public health behaviors, knowledge, how that changed, but also income shocks and food insecurity. So I won't go, in the interest of time, I'm not going to go into the detail here, except to just say that we ultimately ended up collecting data from about a dozen different countries, like on the basis of phone surveys and either nationally representative samples or samples representative of cell phone coverage in the country. And we learned that the effects of the pandemic on the economic side was just unprecedented in depth and scale. Like you could compare it to things like the Great Depression, Asian financial crisis, right? The amount of income loss, employment loss, the increases in food insecurity, right? Every other shock sort of pales in comparison to what happened during the COVID period. And then a second thing I'll point out is that was very important to do when thinking about poorer countries is that all the epidemiological models that governed our decision-making in the US and UK early on were really designed for rich countries in mind, right? Now, the problem with, the complexities that arise when you start thinking about poor countries. So first of all, it's not clear whether the same data and the models apply. So we started doing that, which is let's implement the exact same models, let's calibrate the same model, but calibrate it to developing country data rather than rich country data to see if you get different answers in terms of what the right pandemic response policy should be. And then you actually get different answers. And I'll give you some intuition in a second, right? And second, like if you're calibrating these models, the epidemiologists who are calibrating these models are thinking about idealized situations where, okay, we can implement social distancing and it'll just happen, right? The problem in low and middle income countries is that it doesn't just happen, right? Of course, human behavior plays a large role, especially when enforcement capacity or mandates are going to be limited, right? So that's another reason why you can get very different answers. Okay? And then a third thing that has become clear is that to allow people to survive in such a big economic shock, you really need to provide social protection quickly and efficiently, right? And in poorer countries where the social security infrastructure is not as well developed, it's also difficult to target people who are in need, right? So another thing that's become clear is that many of these countries need to really invest in infrastructure. It could be mobile money, it could be like a national ID system, right? Especially in the absence of, say, a robust tax system where you can get really good information on how much money people are making, right? So if 2 to 4% of people are submitting tax returns in any given year, of course, you can't rely on it like you could in the United States. So you need to come up with a system like that. And you might need to start with more clever, creative approaches. And in Bangladesh, we started working with the cell phone service providers in order to come up with new creative approaches on identifying the poor. Okay, so then the thing I'll end here, this section with is just like, why is it that developing countries demand distinct policy responses? And the main reason is like when you start putting in the developing country data in these models, you actually get very different answers to whether or not social distancing is a sensible strategy. Okay. And the reason you get a different answer is one, the age structure of the population is very different. So there's 6 times as many elderly people in high income countries than there are in low and middle income countries. Okay. And that makes a big difference because COVID and that particular virus, SARS-CoV-2, was particularly dangerous for older people. And the second reason you get a different answer is that as when you remember these models tell us to flatten the curve and through social distancing. So you flatten the curve so that your infection curve does not exceed some healthcare capacity. And if it exceeds the healthcare capacity, that's when you get these unnecessary excess deaths where people are not getting adequate medical care. They don't have a hospital bed, they don't have oxygen, right? And that's why they're dying. Now, the problem is that if you're in a country where the healthcare capacity line is not here, but like down way below, right? Then by flattening the curve and by delaying infections, it's not like oxygen tanks magically appear or hospital beds magically appear 2-3 months later. Now we know it's not even the case that vaccines appear 2-3 months later in these countries. And so then, there's much more limited impact of social distancing policies. And if the benefits of social distancing are lower, right, as you see here, then you have to start thinking about costs. And that's where the microdata we were collecting in Nepal, Bangladesh, Sierra Leone was very helpful in identifying that, look, when you impose lockdowns, that can have really large costs in terms of people's income, employment, and welfare, right? So for example, this is data like in the first week of April of 2020, as soon as the pandemic hit. Or maybe this was mid-April, so right after Nepal's lockdown. And you see that after the lockdown occurred, food insecurity reached a level that you only see, even though it was a harvest period, and during the harvest, food insecurity reached a level that you only see during the lean, hungry seasons normally, right? So this was a big economic shock. Okay, so now with that, so I'm gonna end this section because I do want to be brief and quick about things. I want to jump to talking about masks and then about vaccines. Okay, so so essentially, okay, so why did we do a large mass trial? And this was done in partnership with Stanford Medical School. So it would be great maybe for a different session, you can get some of our colleagues from Stanford Med to participate in your program. And yeah, oh, by the way, I should have said the center that's sponsoring this talk, I was actually very happy to get this invitation because one of the first grants I got after becoming a professor, this was like something like 20 years ago, 19 years ago, was from the Woods Institute for the Environment and the Shorenstein Asia Pacific Research Center. And I have a co-author at Stanford Medical School through which we got this grant. So I've always been very appreciative of the fact that that helped jumpstart our careers. Okay, so so this is a complex trial where we were trying to answer two different questions. So one is, how do we get people to wear masks? That requires a lot of economics, social science, behavior, right? That's the work that we're leading in at Yale. And then once you get people to wear masks, we also want to track whether that actually reduces COVID transmission, right? So that requires epidemiology, blood sample collection, seroprevalence survey, and that work is being led by Stanford Medical School, right? Innovations for Poverty Action has been implementing. And then since the research was done, we have tried to scale up mass distribution in a large number of countries. We're now reaching over 100 million people. And so we've picked up lots of implementing partners. So BRAC in Bangladesh, SEVA, Self-Employed Women's Association in India, Center for Social Behavioral Change in Delhi as well, Lahore University of Management Sciences in Pakistan. And okay, so what are we doing? I'm just going to skip to just one slide on the methodology. So we started with research, and this was a large-scale cluster randomized control trial. Cluster in the sense that there were entire communities, like entire village, everybody who lives there, the mosque that serves the village, the market that serves the village, that's a cluster that gets treated or not, right? So then we have a randomized control trial. So then we randomly select some clusters or communities for treatment where mass promotion occurs, and other communities that are randomized out where that serve as control, where we collect the same data, but we don't do the mass promotion activities. Okay, so this was quite large scale. So we ended up collecting data directly from over 340,000 adults in rural Bangladesh. So just for some benchmarking, say the trial that Pfizer ran to test in the efficacy of vaccines, I think involved around 40,000 people per treatment. And we needed to do this at large scale because, of course, masks, and when you're just handing out masks as opposed to like jabbing somebody with a needle, right? You actually need much larger sample sizes in order to detect effects and make statistically precise statements on whether or not your activities are leading to any changes in COVID transmission. So it's for that second stage, studying the impacts on COVID-19, and the blood samples we have to collect and analyze. That's why the trial is so large. And given that we have such a large sample, right? So that now gave us an opportunity. We were statistically overpowered for the first stage, how to get people to wear masks. So instead of having a one-arm trial, you can end up having a 15, 20-arm trial where you throw many different strategies and getting people to change behavior and start wearing masks. And then I can report to you which of those strategies work. So I'm just gonna, instead of telling you about the whole trial, I'm just going to jump to the bottom line, which is, oh, here's a set of strategies out of the 15 to 20 that we tried. These 4, if you do this jointly, it actually leads to persistent changes in mask wearing. And that, what are we doing? We're going door to door, distributing masks. That's a no-cost N. As at the time that we distribute masks, we provide information about the importance of wearing masks, get endorsement from leaders like the Prime Minister of the country, the captain of the cricket team, the director of the Imam Training Academy. They recorded videos for us. So that was the second component. And then we also had to do secondary distribution at mosque because that's the place where people stand shoulder to shoulder. It's a high transmission risk environment. And that gave us an opportunity to work with the imam of the mosque, who's an important community leader, get him to endorse a concept, also had a script for him that he read out to his congregants, right? And we distributed masks at the mosque as well. And not only did we work with this community leader, we worked with the school headmasters or any elected leaders like a union borsha chairman who may be resident in the village. So we had to get their endorsement as well. We did some miking at markets. And finally, after doing all of this, like we did iterative experimentation and we learned that, okay, we can get mask wearing rates to go up, but not by a ton. It wasn't going up by a ton. So then we added another component, which we called reinforcement. And that's the idea that you can't just distribute masks on day one and just leave the village. You have to go back periodically, right? And we hired mask promoters who would politely intercept people if they were walking around in the community without masks on and ask them, remind them to put their mask on. Look, we distributed masks for free in this village. Why don't you have yours on? Can you go back and get it? Or can you remember to put it on? And if you don't, if you forgot it, then here's a replacement mask. Please put it on, but don't forget it next time because we don't have too many of these to give out. So this interception and the awkward conversation it creates, a little bit of social shaming, that seemed to have worked really well, and it tripled our effect size. And so what is the effect? So let me now just summarize the main results. So first of all, when you do these 4 strategies together, you can get mask wearing rates to change from 13% of households in control areas to 43% of households in treatment areas, right? So there's about a 30 percentage point increase in mask wearing, right? And this is persistent. This is not just a one-time effect, but if you look at the data week to week, you see the treatment group, the mask wearing remains for 10 weeks above the control group. And importantly, this was the day that masks were handed out. And then we did some follow-up, like reinforcement activities. We actually left after this data point. And then these last 2 data points are collected after we've completed all of our intervention activities in the village, and still mask wearing rate remained higher. So that's what got us excited and got us to start, trying to scale up this program, because we were able to change mask wearing behavior through this combination of strategies. And then once you get the mask wearing rate up, what does that do to COVID transmission? So then we go back after a few months and collect blood samples. And so first we ask all 342,000 people about their symptoms. And what you see is that in the areas where you did all this mask promotion and mask wearing went up, there was a 12% reduction in reporting of COVID symptoms. And then to look at symptomatic seropositivity. So people who are symptomatic, we collect their blood sample, we test for COVID seroprevalence. So like COVID antibodies, whether their system had experienced COVID, and you see that in the treatment areas, there was a 9.3% reduction in COVID. Okay, so, and there was a whole bunch of other things we tried that didn't seem to matter in this particular setting. For example, text message reminders didn't really change mask wearing behavior. Getting people to make a verbal commitment, because psychologists tell us sometimes when they do that, they're more likely to follow through. That didn't really help us, right? We tried incentives, etc. That didn't help us. So let me just give you one other bottom line result that is exciting, which is that we tried 2 different masks, so surgical masks and cloth masks. It turns out surgical masks are a lot better. So we saw that in the engineering data. So we designed these masks, tested them in a lab at Stanford, and surgical masks have much higher filtration efficiency than cloth masks. So Laura Kwong, who used to be a postdoc at Stanford, she's now an assistant professor at Berkeley. So she led that work. And so in the surgical mask villages, not only are they better in terms of filtration efficiency, the engineering data tell us that they're better, but on top of that, we also see that in terms of the epidemiology data, we also see that they work better, right? So this is by age group. We see for people older than 60, right, in the surgical mask villages, right, where there was about a 30 percentage point increase in mask wearing, the symptomatic seropositivity went down by about 35%. Okay. And then for people between age 50 and 60, it went down by about 23%, and no statistically significant effect among the younger population. Okay, so we've become really big fans of surgical masks. Okay, so once we found all these results, we decided to scale this program up to reach over. Now we're in the process of distributing masks to over 100 million people, and that's happening in Bangladesh, where our research was done, where I'm from, but also in India, Pakistan, Nepal, and we've started conversations in a couple of African countries now as well. And then Uruguay and Mexico, we worked with the government, collected data, and then decided that this wouldn't be a place to run this program because it turns out it's not necessary. So in Mexico, it could be necessary, but the government didn't want to do it. But in Uruguay, like given the vaccination coverage, it turns out that this wouldn't be the most cost-effective way to spend our money. Okay, so I'm going to skip over a lot of the scale-up partnerships. Okay. And then, so one of the things we learned in the process of scaling up is that now we're moving into new contexts. Like in Pakistan, we're working with the Lahore city government, right? So we started innovating locally about how do we do a project like this, where, of course, the nature of social norms are going to be different in a new context, especially when you're talking about a city rather than rural areas. So Lahore came up with some really nice ideas, which we implemented. Like instead of going door to door distributing masks, we put them in these envelopes, right? So every single resident of Lahore now has now received an envelope with like a Stanford Medical School logo on it. And this is a picture of the health minister sending one of the first envelopes through the post. So we innovated to try and figure out how do we do this cost effectively in various places. Okay, and now we are, okay, so let me stop talking about masks for a second and just say that, yeah, that we'd like to do the same kind of work on vaccines. And I just want to give you 5 minutes on that, and then I'll end. So now, I mean, one of the things we've learned by collecting data across a set of 15 different countries, many low middle-income countries, plus the US and Russia, is that vaccine hesitancy rates are actually not that high in poorer countries. It's not that people are much more hesitant there than they are in the United States. In fact, hesitancy is much higher in the US and even higher in Russia. Okay? So people are willing to accept vaccines, but at the same time, we see supply shortages. But even when supplies are going out, sometimes we're seeing that vaccines aren't getting to people, especially in rural areas, right? So we've been thinking carefully through, okay, what's the model for vaccine delivery? So just like we did the mass work, so the next frontier for us is like, can we also get last mile delivery of vaccines to be more efficient, especially out in rural areas, right? So let me give you the example of Sierra Leone, like one of the 3 places where we're working. We're doing this project in Sierra Leone, in India, and in Pakistan. So in Sierra Leone, now, there isn't, I mean, we've collected the data, there isn't a ton of vaccine hesitancy, but at the same time, vaccines aren't going out to people. Like people, vaccines are expiring before people can take them, right? So in Freetown, there may be good access, but like when you go out to rural areas, the problem is that the nearest vaccination centers for people are too far away for it to be. I mean, it's just so inconvenient that people wouldn't go out and take it, right? So it's not that, like in the US, we are used to thinking about people who are deeply distrustful or reluctant or hesitant about vaccines, right? But really, there's a whole bunch of other people, right, who are much more like indifferent about taking a vaccine. It's just that if you make it convenient, they would take it. But like they're not going to go out of their way and spend an entire day to go visit a vaccination clinic and then also have the risk of like the vaccine not being there. Right? So that's why we need to really work on access. So what we're doing, so for example, in Sierra Leone, what we're doing is thinking about like a hub and spoke system where you get the vaccine, a quantum of vaccines out to sort of community health centers, and from there by motorbikes and a cooler, you take it out to various rural areas. And in the rural areas, you have to be prepared and do some community mobilization activity in advance. So there has to be a separate community mobilization team that goes and talks to the community leaders, the elders, the mammy queens, and help them introduce ourselves to them, and then help them mobilize the community to come get vaccines, and that we'll bring it. And the next day in a motorbike, along with the nurse, somebody who's qualified to give the vaccine, we show up with the vaccine in order to make the access much easier, right? So what we're in the middle of doing right now is in Pakistan, Sierra Leone, and India, we're designing interventions like this to improve access. So I just described rural Sierra Leone, which is about motorbikes and going out to very remote, inaccessible areas. Now in urban Pakistan, in Lahore, right, it looks different. We're setting up vaccination centers. I think I have a picture on this. Yeah, temporary vaccination centers in various neighborhoods, right? And then we're also doing a lot of mobilization, right, which is that we've hired lots of university students at LUMS, Lahore University of Management Sciences, who are trained to now go out and knock on doors and try to get people to these vaccination centers that are in their neighborhood to try to make it more accessible. Right? So again, the idea is that in the mask case, we move from, okay, there's research. We need to figure out how to get people to wear masks. And then we have to do some research on whether that's actually effective. Now in the vaccine case, we have to redo this process of can we identify models that will get people to quickly take vaccines such that we can do vaccine delivery more efficiently and cost effectively, right? And thankfully, we don't actually have to do the second stage, the expensive part, because Pfizer, Moderna, J&J, all of them have done the second part already, which is that vaccines, yes, they are effective. And so as social scientists, our job is to try and figure out how to get people to take them. All right, so I'm going to stop there. So that's the three things I want to talk about. I'm happy to have a conversation.
Great, thank you so much. So for all of our attendees today, if you would like to put your questions in the Q&A, that would be wonderful. So I'll start with some of those and then we will get to other ones as they come in. So thank you so much for the presentation. You went over a lot of details rather quickly. So we had one question initially coming in, just some of the basics about the time period of the intervention and how much the surgical mask costs.
Yeah. Okay. So the time period of the intervention is basically 8 weeks. So we started. I mean, like if you think of the door-to-door mass distribution of community as day one, right? The community leader engagement, the reinforcement work, the visiting of mosques, and then the miking and market, all of that we were doing periodically for 8 weeks, not constantly. So like, for example, the reinforcement work, going and reminding people to wear their masks, we started by doing it 3 times a week, and then we sort of scaled down to twice a week, then once a week, and then after 8 weeks, it was down to 0. So yeah, like the engagement, our presence in the village, you should say, you should think about it as an 8-week period. Okay? And now on the surgical mask, so over the course of this trial, our research team became much bigger fans of the surgical mask option, partly because of what you just asked about, which is about cost. Okay? In fact, I'm gonna skip back over to that screen on surgical mask so I can show you. All right. So initially, why did we test both cloth and surgical masks? It's because there was true equipoise as to what would work better, right? So we liked the surgical mask option. It was cheaper. The filtration efficiency tests were telling us that they're much higher efficiency. They work better than cloth masks. On the other hand, we had conversations, of course, before launching the trial. We had conversations with lots of experts, my competitors, who are based in Bangladesh, like ICDDRB, International Center for Diarrheal Disease Research, that does public health work, but also with the DG of Health. So the Associate Director General of Health is actually a co-author on our study. She's like number 2 in command in the country for public health policy during the pandemic. And so they had a strong prior that, look, the surgical masks will not work in Bangladesh. And the prior comes from the fact that like people view these as like one-time use things, right? And they're like thought of as low quality, whereas cloth masks are the ones that would work, right? So given what they were telling us versus what we are seeing in the engineering data, we said, okay, like one way to work through this is that let's test both, and we'll randomize which village, which community gets which, and then we can see which works better, right? Right, so ultimately we see surgical masks work better. We have much clearer evidence that they save lives. Okay, so now why? Okay, so that's one big reason for us to get excited about it. A second big reason is that at scale, we can now order these surgical masks for like 4, 5, 6 cents. Okay, whereas cloth masks, the triple layer, the ones we designed at Stanford, like interwoven fabric, etc., would cost at least 40 to 50 cents. Okay, so I mean, a difference of 30 cents may not sound like much, but like if you're trying to distribute masks to over 100 million people, like that's a lot, right? It turns out any number you multiply by 100 million, it's a big number. So so that's why, like, we're trying to be cost effective. Okay? And the other thing that I want to leave you with is that these masks, like in a hospital setting, we're used to like just throwing them away after one-time use. Yeah, if you're doing surgery, you should not be reusing the mask. But most of us are not doing surgery, and when we're using these masks, we should be washing and wearing them, reusing them. And we tested that. So we took these masks, like a bunch of samples. We took them to the Tata Institute of Fundamental Research in Mumbai, and then what we did was we washed it with like wheel soap, the type of soap wash that like people in rural India would use. Wore it, washed it again, wore it like 20 times, and then tested filtration efficiency over and over. And even so, this surgical mask started out at like 97% efficiency even after 20 washes. it's at like 81%, whereas a good quality triple layer cloth mask starts out at about 37 to 40% filtration efficiency. Okay? So anyway, use these, wash and reuse them, because we also care about the environmental impact of these masks. And in order to send that signal in during our trial, we put a sticker on each mask where in Bangla it says below, you can wash these masks and reuse them.
Excellent, thank you. So have you had a lot of reaction to that specific finding of your research of the surgical versus cloth masks? And related to that, in your scaling up, are you continuing to study the impact going forward?
Yeah, okay, so on cloth versus surgical, yeah, I think one of the things I noticed is that the fact that surgical masks are reusable comes as a big surprise to people. So that's one of the things that people have learned, and like that generates a lot of conversation. So we've had separate conversations and made videos, including Steve Luby at Stanford made a little video about the reusability of these masks. Okay? And recently, I think the Atlantic, they didn't talk to us, but they cited our study, and the Atlantic had a nice feature on, which was titled something like, "Why the heck are we all still wearing cloth masks?" Okay? Still, and like still in bold font or something. So it has led to some of these conversations. Okay, and now at the scaling process, yes, so we're continuing to do monitoring, right? So, and that monitoring has occurred in Bangladesh. In Pakistan, we're actually doing monitoring as an RCT as well, right? And then in Bangladesh, we're doing monitoring of the rural scale up, like where BRAC, the biggest NGO in the world, they're going out and trying to get these masks out to 81 million people. So that's the responsibility that the government gave us. So the NORM team and the BRAC team are working together on that. And separately, we're working with the Dhaka North City Corporation, the Dhaka mayor, and we've done monitoring of a pilot there. And on the basis of the monitoring, we just presented results to the mayor, and we're planning to scale this program up and covering other cities like all of Dhaka, Chittagong, Rajshahi, etc. So it's important for us to continue to collect data, because the thing is that you don't want to declare victory too early, right? Like the RCT results look very promising, but of course, as you start taking things to scale, things aren't going to replicate the same way. Like implementation details change. The intensity of efforts have to change, right? And that might matter, right? So we're like basically collecting information and hoping that like the implementing partners will course correct if necessary based on more and more information. Did I add a question? Yeah.
Fascinating, yes, thank you. So as you know, the theme of our webinar series is aligning incentives, and your research well underscores the importance of this. Maybe you could talk for a minute about this study and your other work about how you go about aligning incentives, sort of figuring out what the incentives are of the different parties and how they may work together. Like it appears in your study that financial incentives didn't work so much as understanding the incentives and then reinforcing and modeling.
Yeah. Okay. So here I have to be careful about language, because when economists talk about incentives, we mean something very specific, which is, say, like the type of thing we tried out, which could be a financial incentive, which conditional on you wearing a mask or the mask wearing rate in this community changing, I will give the community something, right? And that something could be a financial incentive, like actually explicitly like some amount of money that the community can use for something. It could also be a personal incentive, so you could like actually pay people to get a vaccine, for example, right? But it could also be non-monetary rewards, right? So this comes from like a common use of this is in the sanitation sector. So in India, like there's this use of, say, a reward called the open defecation free village. Like you give that certificate, right, if the community manages to change its sanitation behavior, right? So those are the types of things that we think of as incentives, right? But of course, in the public health setting, you might also think about provider incentives, right? Not for the demand side, but for the supply side, right? But in the way, the Karen that you just used the term, I guess, is thinking more broadly about what it is that people care about, right? And so in this case, so let me talk about what I think actually ends up mattering here, what we think people care about. So I'm just not using the term incentive for it. I'm just trying to figure out like what drives people, right? So in this case, the reason why we use the acronym NORM, N-O-R-M, to describe our model, right, is because I think it's like what it does is change the social norm, which is why we might see persistent effects, like even after the intervention period ends, right? So where would that persistent come from? And there's some not only from us, but also there's some other research now of like what we would call it, like survey experiments, where people are asked about their intention, right? And some other research finds the following as well, which is that like what you do is strongly dependent on what other people around you are doing, right? So one easy way to say it is that if you or I were wearing masks in either Palo Alto or New Haven in February of 2020, right? People would look at you funny, and in fact, a lot of the reactions would be, let's avoid this person because this person has some deadly disease that like we don't know about, just because it's like, oh, that's weird behavior, right? Whereas if you or I, let's not change anything about our neighbors or us, right? If we walked around New Haven or Palo Alto without a mask on in February of 2021, right, people would avoid us and think about like, what is wrong with this person, right? So behavior completely shifted. So in this case, social norms were really important drivers of behavior, right? And so what are social norms? It's like my returns to doing something is dependent on what other people are doing, right? Even if I don't, so you see this in sanitation as well. Like you put me in rural India, I might just go out in the open. It doesn't make sense for me to invest $50 on a toilet, right? Because everybody else around me goes out in the open, and that's expected, right? And now you take me and put me in Palo Alto, right? If I go and continue my behavior, you guys might complain. And so I'm going to stop. Right? So I think social norms really matter here, right? And so we were trying to figure out, okay, how do we sort of prime people to think about these norms, right? So that's why, like, elements of our intervention, which is that we did go door to door, right? Not everybody in the village needed a mask; they already had one. Not everybody is poor, right? But it was important for us to still go door to door and give it to everybody, so that nobody has an excuse, right? Everybody knows that, like, you don't have an excuse that, oh, I didn't get one, okay? And everybody knowing that everybody got one was important driver of that behavior.
Right, fascinating. It was an interesting example because I actually did wear a mask in late January 2020, and people were looking at me a little strange, but a family member had just come back from China. So there are some questions here, though, related to that. I wanted to ask you, because the norm, of course, includes information as well as changing what motivates people, right? And someone was asking whether there's information that is incorrect. You talked about sort of vaccine acceptance. It's more about convenience, maybe. But someone was asking, is there any information about misinformation or conspiracy theories? Does that, in fact, impact the rollout in the places you're studying?
Right. Oh yeah. So this is actually. Oh, I think that was Hassan from Sierra Leone who's asking this. Hey, nice to see you here, Hassan. So yeah, so we, when we wrote this other paper that's in. You can, if you just search for my name and if you want to read it, it's in the journal Nature Medicine. Okay? So where we collected data from 15 different countries and the same set of questions that were asked of 44,000 people across 15 countries, including Sierra Leone, right, and other nearby poor countries as well, like Rwanda, right, Ghana. We have several countries in Africa, but also like Colombia, Philippines, United States, and Russia. Okay, so the things that we learned from that study. So one is that like vaccine hesitancy in Sierra Leone is actually lower than it is in the United States. It's lower than in a lot of like richer countries. Okay? People are not deeply hesitant. Second, okay, the people who don't want to take the vaccine, what are they worried about? And now I'm talking about all low middle income countries. It's not that the conspiracy theories are not the things that come up very often, right? The people who don't want to take the vaccine, right? The most common reasons they give are worries about side effects, okay? As well as worries about whether or not this vaccine is actually effective. Right? So this was all done before the vaccines were widespread. So we conducted these surveys in late 2020. Okay? And so, yeah, I think we, like things like conspiracy theories get a lot of play in the media, right? But when you look at representative samples, large samples of people, and when you ask these questions, they seem to be worried about things that are quite rational, right? which is there may be side effects, and I don't know how my body will react to it, and especially if I have to miss work, that may be very costly. Right? Things that all of us would care about. So I think it's, I'm not saying that there aren't deeply hesitant people. I'm not saying there aren't people who have various conspiracies in mind, right? But that's not the representative case.
Thank you. So there's also a question about what some of the main accomplishments of the research have been. And I just wanted to follow up by saying perhaps part of the work is not only showing the effectiveness of masks, particularly surgical masks, but also building these partnerships and showing the effectiveness of evidence-based policy during a crisis and beyond. I wonder if you want to comment about that?
Yeah. Yeah, so that's complicated, I mean, there's some research in it. Research does matter, but there's a lot of other skills or elements in it that have nothing to do with evidence and research, right? So I think, okay, so let me tell you about now I'll sort of depart from data and talk more generally about what I think worked or didn't. Right? So first of all, I think evidence mattered here. And the reason is that, you give people something tangible, which is, look, there's a lot of this conversation that's happening back and forth, masks work, masks don't work, or you can't really get people to wear masks, it's too difficult, like people, just like behavior change is difficult, right? And for us to have some hard evidence that, look, we can tell you exact set of 4 things. I mean, it's not easy. You can't just go and distribute masks. There are 4 things that are interrelated. You have to do them jointly, right? And if you do them properly and jointly, then behavior does change, and it changes in a persistent way, right? So going with a strong message based on rigorous data, I think did matter. Okay? People do care about evidence. Okay? But second, right, like for me to be able to make that phone call and say that, look, I have some interesting results for you to look at, right? That's not going to happen organically, right? And especially not so quickly as we had to do it. So what happened in this, so now to give you the timeline. So we were doing the study from November to April because there were different communities that were sort of being staggered in, right? And then the crisis hit India in April. So this was the first stage of getting people to wear masks. And in April, already a really bad crisis hits India, right? So at this point, I have the data back on what can we, how large are people's response to mask wearing, getting them to wear masks. So I knew the first stage, but I knew nothing about the second stage yet, which is this actually saving lives? Because for that, we got to wait for 2 months for the antibodies, to develop, if that actually is going to change, and then take blood spots, then send them to a lab, analyze those blood spots, and only then can I report those results, which we started doing in the summer of 2021. So but then since the crisis in India, I needed to move quickly. I was like, okay, look, we have sufficient evidence. Even before my randomized control trial, my belief is that masks actually work because of non-experimental evidence that I knew of, right? And so I felt like it was my ethical responsibility to distribute masks quickly so that India, the spread slows down and we don't see that kind of a crisis in neighboring countries like India, Pakistan, Pakistan, Bangladesh, and Nepal, right? So that's why we went to work right away, even before seeing the second stage results. And we really promoted, explained to people exactly what the first stage was, how we get people to change their behavior. And we focused on countries where the risk was high, like surrounding countries nearby India, and also several states in India. Okay. Now, okay, so we needed to move very quickly. So this is the part I want to talk about. So now the way, for me to be able to make that call and get them to listen right away, right? That doesn't happen overnight. It's not like I can come in as a random person who just say, yeah, you need to listen to me now, right? It was partly, I mean, what opened the doors was because for the previous, 12 to 14 months, we had been doing a lot of data collection and feeding governments with that data in Pakistan, in Bangladesh, in Nepal, in Sierra Leone, right? And that thankfully generated a lot of goodwill, right? Which led to okay, I'll take this call, right? Even though I'm extremely busy right now, I'll take this call. Let me hear you out. And then having, I hate to say this is not fair, but having names like Stanford and Yale behind the research, right, also matters to the people on the demand side, on the policymaking side. Right? because my name is not going to carry any weight, but the fact that there's somebody from Yale University saying this ends up carrying more weight.
Right. Well, Steve Luby did present the aspect of the mask design, et cetera, at the health policy seminar just last week. So it's really wonderful that you've built these partnerships and established credibility. I wonder if you can share with particularly our young people, our students, our postdocs and beyond about how to navigate that road of investing in careful, detailed research, building partnerships in the field to have impact, and focusing on establishing relationships in academia and beyond, wherever they're planning to spend their career. Any advice about how to balance all those during a crisis and beyond?
Okay, yeah. I mean, Karen, your just a question itself was such a mouthful, right? With 4 different dimensions of, or 3 different dimensions of life that you were asking people to take on. That itself says that, look, this is complicated, right? So actually, I'm going to actually have to say almost the opposite, right? For young people, especially graduate students, postdocs, right? That this shouldn't be your responsibility. This shouldn't be any of our responsibility. The way the world should work, right, is that there are people who specialize in evidence generation who know how to do that, right? And even within evidence generation, there are people in medical schools who are experts at the epidemiological evidence. There are people at economics departments or business schools or social science departments that are experts on the psychology, the economics of behavior change, right? We should focus on what we're good at, right? And have other people who are in communication and people who are policymakers, right? And there should be evidence should get in the hands of policymakers more quickly and efficiently, right, and seamlessly without having to spend a lot of extra effort in pushing and marketing what you find, right? So unfortunately, the world doesn't work like that. Okay, but that doesn't that doesn't necessarily mean that it's your responsibility. And I say this because I also care about, especially young people and mental health and family life, because you're in a place where you're not just a robot. You're not just working. You might have family. You might have a spouse. You might have children, right? And so what we this is also take everything I say with a grain of salt, because part of this is survivorship bias, right? I'm here speaking, whereas Karen invited me and the center invited me partly because this worked, right? But a lot of these things fail. I have for this successful project I'm describing, I have 5 to 10 failures, right, that we're not talking about. Okay? So these things are risky, right? That's what I mean to say. They're very risky, and so especially early in your career, right? People are if you're at Stanford, the provost and your department chair and your colleagues expect a certain set of outputs from you, right? And it's not clear that investing time in making policy connections is necessarily the best use of your time, right? So you have to think about that carefully, because it all comes at a cost. We have been, our team, I have an incredible team that worked on this, worked on Norm. But we were, after the crisis in India, all of us were putting in 14, 15-hour days, right? And really, that's not sustainable. It's not sustainable for any of our mental health either. So you have to be careful. So I want to actually say, yeah, I mean, it's great when you can do good things for the world, but at the same time, you have other responsibilities, and let's be aware of that too.
Yeah, thank you for reminding about the balance. So to our listeners, thank you so much for joining. If you have any final question, put them in the Q&A, because we're about to wrap up. I would just invite any of your final thoughts, particularly going back maybe to the topic about vaccines and moving forward. What can we do to enhance vaccine equity and help everybody move beyond this pandemic?
Yeah, I think we've this has been a big ethical lapse on our part. We are not doing what I think we have a responsibility to do, which is getting vaccines in the hands of people in lower income and middle income countries. And okay, so the ethics of it, I guess it's not, that's not neither here nor there. That's not going to necessarily change people's, reminding people of their ethical responsibility may not necessarily change the country's behavior. But I'll say something a little bit different, which is that when people it's a global pandemic where all our lives are interrelated, right? So even if you're completely selfish, let's say we don't care at all about lives in other countries, okay? We're completely selfish, we just want to protect ourselves, right? Even in that situation, like I just say, okay, that's our objective function. We just want to protect American lives. Okay? Even with that objective in mind, right? Giving vaccines to people in lower middle income countries where very vulnerable populations don't actually have access to vaccines might be a better use of our vaccines, even if we're completely selfish, than trying to give third booster doses. And the reason is, if you leave large populations unvaccinated, right, as we saw with the Delta variant, the virus has chances to mutate, right? And when I say the world is interconnected, once it mutates, it will get re-imported back. And so, God forbid, we get a mutation that is resistant to the Pfizer Moderna vaccines, then we're just back to square one. Right? So I think there's ample reason, even if you're selfish, for us to have more equitable distribution.
Thank you. And I like to try to end on a positive note, if possible. If you want to tell us what you think you're looking forward to, and particularly given your comparative research across South Asia, if you can share with us some things that you think we can take from this time and moment forward with optimism, please share.
Sure. Okay. Yeah, so what I'm really looking forward to is demonstrating soon that these arguments that, look, if we give vaccines to people in poor countries, it doesn't get taken up, it gets wasted anyway, right? I really want to demonstrate that it's possible for us to set up systems such that vaccines get distributed effectively, efficiently, like even to various remote regions, right, rural regions of those countries, so that that particular counter argument just gets taken away, because I think it really is about access. It's not about hesitancy, right? So I'm kind of doubling down on like trying to generate that noise. And optimism. This is 2021 after all. The other thing here is so something positive that's come out of it is we've learned some new things, including much closer interaction between researchers and policymakers, right? So during this pandemic, I have noticed that the Bangladesh government and not only the government as a whole, but various units within government, the interaction between NGOs and government, etc., they've become a lot more seamless. So I can much more easily get research results on the desks of important policymakers now than was possible for years before the pandemic, right? So I think we should take advantage of that. And so in the interest of evidence-based policy, I think this is going to have some long-term beneficial impact for all of us.
Well, thank you so much for the work that you do and for sharing it with us, for building that trust and trying to address this crisis and beyond. So thank you all to our listeners today. Hope you are well. And thank you again, Professor Mobarak.
Thank you, Karen. Thank you, Lisa, for organizing. Thank you, everybody, for being here.